Okay, good evening and a warm welcome, everyone. There's a funny echo. Good evening and a warm welcome to our public lecture. My name is Matthias Eberl. I'm Professor of Translational Immunology at Cardiff University, and I'm one of the co-leads for public involvement and in public engagement in the School of Medicine there. So today, we're going to talk about the fact that every day healthcare professionals make countless decisions that keep patients safe. And sometimes things can go wrong. Improving patient safety, therefore, requires understanding of how healthcare systems really work so that they can be redesigned to minimize risks for future patients. So it's our great pleasure tonight to host Professor Carson-Stevens, who will explore in this lecture how safety emerges from everyday practice. So he will draw on his research led by his team at Cardiff University and others, and explain why traditional approaches to learning from error are not enough, and how patients, professionals, and organizations on a whole can work together to design safer systems and improve outcomes across healthcare systems. The talk itself will be around 40 minutes. There will be then a Q&A session afterwards where you're invited to ask any questions you like. And at the end of the whole lecture, we will also have some opportunity for you to provide feedback, and we will ask a few questions about your experience with this whole lecture setup. So just briefly, Professor Andrew Carson-Stevens is Clinical Professor of Patient Safety at the Division of Population Medicine in the School of Medicine in Cardiff. He's also Director of the WHO Collaborating Center for Patient Safety, Learning and Improvement. He convenes the so-called PISA group, that's the Patient Safety Research Group at the university that investigates the nature and burden of avoidable harm in healthcare and measure safety outcomes in health and social care. He coordinates the Welsh Ergonomics and Safer Patients Alliance, WESPA, which is an interdisciplinary group of researchers and clinical academics working to improve patient safety in the NHS. And he's director of PRIME, the Primary and Emergency Care Research Centre, which is a Health and Care Research Wales funded collaboration across 4 Welsh universities, with a focus on improving the quality and safety of primary and emergency care delivery. So without further ado, I hand over to Professor Carson-Stevens, and we're very much looking forward to your lecture.
Diolch, thank you. Noswaith, good evening. Thank you for joining this public lecture. I'm a GP and I research the safety of healthcare, and during this lecture I really want to help make sense of why healthcare sometimes goes wrong and share with you how we can learn from that to improve care for the public, for patients and for service users. Now, data's everywhere. Data's being collected about me from my mobile phone right now. The supermarkets will know exactly what I'll buy from them next week before I do, and healthcare is really no different. There's a lot of data in our healthcare systems that can help us to understand when care goes right and when care goes wrong. And that's what my group at Cardiff University does. We've got a particular expertise in developing approaches to optimizing and making the most from different sources of such information that exist within organizations like the National Health Service. And we try to understand where and how those systems can be improved to deliver safer care. We also share our expertise across the country, across Wales, and work with a large team of people passionate and focused on leading research aiming to improve the quality and safety of primary and emergency care delivery, as well as to prepare future generations of scholars here in Wales to lead research in that context. And we hope by working together as passionately as we do to make a huge difference to you and your loved ones the next time you see a healthcare professional. And globally, we share our expertise through our commitment to the World Health Organization and its leaders to improve patient safety worldwide as a WHO collaborating centre for patient safety learning and improvement here at the Division of Population Medicine in our School of Medicine at Cardiff University. And that means that alongside this brilliant team of dedicated professionals in this picture, we work with the World Health Organization in many different ways, but especially to understand where and how countries are making progress to implement its 10-year Global Patient Safety Action Plan, which I had the honour of contributing to some years ago in the thick of the pandemic. And it's a 10-year plan with 35 strategies aiming to improve the safety of healthcare for all. Now, that action plan provides a single plan for the world where countries can learn with, from, and about one another's efforts to implement those strategies. And our team at Cardiff University help to capture that learning, to inform reports like that one shown here, the Global Patient Safety Report in 2024. And this coordinated and strategic effort was needed because every year millions of people are harmed around the world while receiving healthcare. And global estimates suggest 1 in 20 people will experience a safety event, and a large proportion of those really will experience a serious or fatal outcome. Now, about 1 in 10 then will probably, and you might hear this talked about in terms like people receiving the wrong medications causing side effects, or infections that they've caught in hospitals, delayed or misdiagnoses, for example. And in primary care, about 2 to 3 safety events occur for every 100 consultations, and 1 in 25 patients will experience severe harm. We investigated the scale and burden of this problem in general practice in England, and we were working with colleagues at the University of Nottingham, Manchester and Edinburgh. And we found many of these safety events are largely preventable. We looked in the clinical records of people that had developed significant health problems like heart attacks, strokes, loss of eyesight, extreme pain. And in 97% of cases, professionals did all they could. They were diagnosed in a timely way and they were appropriately managed. But the 3%, there were commonly problems with timeliness and management resulting in harm. And we found that these cases of harm were due to issues around how the care system was designed. I'm not ignoring the fact that professional misconduct is out there, that it does occur, and it must be addressed, of course, when it does, but we didn't find evidence of that in our study. And I think it's important to be clear at the outset that the health service, the vast majority of people working in those systems, they're highly skilled, they're deeply committed, and they're doing the best they can under significant pressure or systemic constraints, as it's often called. And what I mean when I say cases of harm due to the way that the care system was designed, I'm referring to the conditions in which people will work on day in, day out. And you can see that shown here on the left, the staffing levels, workload, availability of key equipment, the clarity of policies, even the culture influencing whether people feel able to speak up or not when something feels unsafe. Nothing on the left here is a mystery. We do know how to fix these sorts of problems, but the challenge is not just in both understanding what problems exist and their nature, so that we can make well-informed plans to improve the system and minimize risk of recurring challenges, but it's also in the implementation of and ensuring that we have a reliable way of mitigating those things from happening on a regular basis. The solutions to these system challenges are already known and quite achievable, but it's that consistent and reliable delivery of safe conditions across settings, teams and time that's the really challenging bit. And there is a real urgency to act. In our primary care study, we estimated between 19,000 and 32,000 cases of avoidable significant harm occurred in general practice each year. Now that's up to 32,000 people that required more intensive intervention that might otherwise have been required. For example, an additional operation or hospital admission, and sadly, even death. So how can healthcare learn to be safer from when it goes right and wrong? To help answer this, let me begin by sharing with you a photograph of one of the most famous landscapes in the world. It's a view from an inpatient bedroom in a former asylum in Saint-Remy, Provence. Now, you will know it better in this form as the Van Gogh masterpiece. Of course, it's the Starry Night. The photograph captures the scene as it is, the colours, the lights, the shapes, roughly as you would perhaps experience it if you were standing there yourself in that moment. It's quite striking, the similarity between that photograph and this painting. But the painting, however, is something else entirely. It's not the landscape itself. We know that. It's one person's interpretation of that landscape. And I think health services research works in a very similar way. When we try to understand how healthcare works, or why safety events occur, or why services struggle, why things go wrong despite good intentions, we're almost never standing in the landscape itself at the moment that care is delivered. Instead, we rely on working with many different fragments of information. And I've been thinking about how it can sometimes feel as a researcher that what I'm able to produce is closer to a jigsaw of a painting rather than a photograph. It's an interpretation, a way of synthesizing many partial views into something that help us understand a complex issue, where each data source shows us something, but none of them show us everything, where each fragment of information gives us something, but none, of course, gives us everything. But the struggle we have in healthcare is bringing all the different insights and signals together to construct, if you like, as complete view of the problem that we need in order to understand the underlying issues, to act in an informed and effective way. We also have a lot of information, and many great scholars have criticised we do too little with it. And for those in the system, they tell us that it can feel like this is sometimes the best view of the problem they can achieve when they want to understand a problem. And that could be owing to poor access to data, even knowing what data exists, knowing how to tease out the learning from it, and I could go on. And this has been a big driving force for us at the PISA group. How can healthcare systems optimize their approach to learning to move from this view and understanding of patient safety shown here to this one? And that requires strategy to get the most from the data available to us, as well as the data we can collect and seek to fill in some of these gaps here, perhaps. Health services researchers collect and we generate data to build up this understanding of phenomena like patient safety. And in my field of safety, this pursuit of understanding risks to patients, it allows us the identification of where and how the system could be improved so that we can mitigate such risks to future patients. But we can use many different sources of data, of course, and when WHO asked countries around the world about how it measured patient safety, you can see here on this diagram, it was clear many different approaches were in use, and some were more in use than others. And many of these approaches to learning are in use within the United Kingdom right now. Some sources will provide narrow lenses on the issue. To understand the complexities really of unsafe care, we can use databases called instant reporting and learning systems, where frontline professionals, doctors, nurses, pharmacists, physios, they can report and they can describe safety events. And this is an approach advocated by the WHO. They advocate the establishing or sustaining of these sorts of systems in that 10-year patient safety plan I talked about earlier. And then I suppose here on the right, at the other end of the spectrum, really intensive type investigations can get us up close to an issue. And those investigations happen day in and day out in healthcare, and they can provide us with detailed insight. There are many sources of patient safety data. This is not a series of lectures. I don't have you for 14 hours or four, but for this lecture, I'd pick just one to really, I hope, demonstrate the utility, the ability of us in healthcare to use that data and how we as a research team are working with healthcare leaders to learn from such data. So let me tell you a bit more now then about patient safety incident reports. This is what one looks like. It's written, as I said, by frontline healthcare professionals, in some systems even by patients and families, to describe the events they were witness to or experienced. And that's whether something bad happened or it was a near miss and it didn't because someone got there before, or even when no harm occurred. It's about learning. And England and Wales, they've long been ahead of the curve and jointly launched a national system in 2003 where healthcare professionals and in some cases, as I say, patients that have been witness to these safety events, they could write reports about what happened, their perceptions about why, and the outcome. What happened? How would you describe that if someone asked you what the consequences were, of course? And organisations shared those reports to a national system. And that national system accrued 23 million reports over a number of years, really close to 20 years, just over, I think. The largest system of its kind in the world. And now both England and Wales have got their own system. Now our group at Cardiff University, we've extensively analysed these reports from what used to be called the National Reporting and Learning System, as well as their follow-on systems. And we've made real advances in how to optimize the identification and extraction of this essential learning from such data. It all started when we investigated the nature of unsafe primary care using incident reports. And at the time, the World Health Organization had highlighted concerns that relatively little was known about the safety of general practice and primary care compared to what we knew about hospital safety. And that was around about 2012, 2013. So I convened a team of colleagues from around the world to carry out what was colloquially called the PISA study. And it remains the largest study of its kind in the world. But we learned a great deal about the sources of unsafe care in general practice. And importantly, it allowed us to learn so much about the strengths and the limitations of these data to realise their full potential. We looked, though, at 13,699 reports taken from around 42,000 that were available at the time. So nearly a third of what we could have looked at. And really, we saw these as 13,699 jigsaw pieces of a puzzle to understand this unresearched, under-researched phenomenon. However, once we got stuck in, many of these reports were incomplete. By that, they didn't describe what had gone wrong. They didn't contain key information that we needed for learning purposes. That meant, what I mean by that is they didn't describe why things went wrong. And it's this finding which mattered most to us, because without those insights from people who were there telling us why they think this thing occurred, why the safety event occurred, the reports actually hold very limited value for helping us understand this where and how piece of where the system can be improved, designed, redesigned to be safer for patient safety improvement. And another thing we found was these reports were absolutely laden with blame. People were blaming themselves, blaming others, blaming other teams and professionals and so on. But we saw potential where each incident report, if you like, was a window on the healthcare system. And each report was a story about somebody, a patient's experience, or even a family member's experience in that healthcare system that we felt confident we could extract learning from. And for those with that key information that met those criteria and I just went through about what went wrong and why, we developed a consistent way to extract the key information. And that was what happened, why, and what was the outcome. Whereas it may be difficult to identify the learning in stories like this, they're lengthy, and really the learning is locked away. But it can be quickly coded to be this. The same story can be represented visually, but also in a more simplistic form. And that's what we did. We developed a process in order to take this and convert it to this. Now, when you view each report then as a source of ideas for change, and that when you're combining those with other reports that are similar in nature, perhaps they were all about older adults receiving primary care, for example, bringing those reports together is an important opportunity to spot common patterns in what's going wrong and why. And at Cardiff, we've honed that science for bringing structure and order to making sense of really complex stories in a way that's allowed us to identify priorities that future healthcare professionals can consider when they're working on improving the safety of care that they are trying to improve. Now, this is a typical story shown here. Delays at every step in this story, and every country in the world would recognise it. And here's the exciting opportunity for global learning. When I was first creating what eventually became called the PISA classification system, that just means we had a series of coding frameworks with codes, words that describe certain features. It struck me that there was a real opportunity in and learning from how accident investigators in fields like aviation, how they could come from all over the world, not speak the same languages, different languages, yet investigate the same accident and still share their findings as one voice, because they had a universal way of communicating their findings. And so, like their system, our code book has been translated to many languages, but importantly, each code has a unique number, and numbers are very universal. And so the same patient story and series events would be coded the same in English, as it would be in Japanese, as it would be in Portuguese, and so on, to the point where it would look like this, and we've removed the language barrier this way. So we've developed a system that can allow these discussions about safety to happen around the world without language barriers. Now, in most of these databases where these reports exist, you very often have key elements of information like where the event occurred, the age of the person, sometimes the names of the drugs that are involved. And that allows us to create and find samples of reports with common characteristics. And when we were starting out, one of our medical students, who's now an honorary lecturer at Cardiff University and training to be a paediatrician in London, Dr. Pippa Rees, she was passionate about improving the safety of care delivered to children. And Pippa saw challenges in the vaccination delivery process from her clinical practice when she was on placement as a student here in Cardiff. And we looked in the database and we found that there were 2,298 reports involving children receiving a vaccine in general practice where something did not go as planned. And we appreciated quickly that what sounds straightforward, giving a child a vaccine, involved a lot of steps and indeed a lot of different people. And when we looked at the relationship between what went wrong and why, we identified several unique reasons for why different parts of the vaccine delivery process could go wrong. Now, if we focus on the 2 o'clock position, it was apparent that when a doctor or a nurse was selecting a vaccine to prepare it for a child, that this was problematic when two vaccines had similar looking packaging, although similar boxes were next to one another on a shelf. And as a research team, we pulled all the reports where these issues were present, and we reread those reports to glean insights that might help us think about recommendations to try and improve and mitigate future similar issues. And we identified a lot of ideas for change just on that 2 o'clock position and those relationships. And we found practice level opportunities as well as areas which could be taken up with manufacturers of vaccines, as well as messages for policymakers. And for the practice level ideas, should a GP surgery experience a safety event involving a child receiving a vaccine, then they could review our paper and reflect on where and how they might go about improving their work system to try and mitigate future risk to children in their practice too. Over many years, we've worked closely with key organisations like the Royal College of General Practitioners to develop practical guides, online training resources to help frontline teams move from data to ideas for change, to inform their actions to improve the safety of care that they deliver to their patients. And to develop those plans, they will be drawing on all their experiences and the confidence which comes from the times when care was delivered safely to children, not just when things go wrong. Healthcare goes right more than it goes wrong, of course. Over 15 or so years, we've applied these methods now across hospital, community settings, even in prisons. And there have been many patient safety issues to unravel, each generating a vast amount of learning in the process. Now, we've typically focused on understanding risks for those that have been under-researched, those we know less about in society, those that we don't know as much about the risks for example. We've studied harms arising from discharge from hospital to home or diagnostic errors in the emergency department. We've carried out work focused on populations where little is really known about the safety of that care. So that would include people who reside in prisons, children with physical, psychological or social care needs, for example, as well as individuals receiving even things like opioid substitution therapy. With these databases, you can carry out very specific searches as well as very general searches and very quickly arrive at a large sample of reports to glean learning from. And these reports, they've provided such a unique opportunity to study complex issues in healthcare. And really, if we stood around in clinics and operating rooms waiting for safety events to happen, we really would miss out on an awful lot of them. And remember, healthcare is safe most of the time, but through these reports, we've been able to carry out some of the most focused and even largest patient safety studies of their kind. And we've used findings from these studies in lots of different ways. For example, we regularly work with patients and the public, healthcare professionals, leaders, managers, planners, to turn our findings into plans for improvement. Following this study shown here, we worked with a diverse stakeholder group in Newport, South Wales, to improve the safety of out-of-hours end-of-life care. And interestingly, much of those conversations were not focused on what went wrong, as I alluded to earlier, but they were action orientated. People were thinking about safer ways of delivering care and what that could look like. And very often they would draw on those positive experiences of when care went right as opposed to when care went wrong. So we're using these instant reports, if you like, to bring to the fore the issues that people are experiencing, but the solutions are emergent through people's lived experience of when it went right and what art of possible could look like and what great care should look and feel like, and how do we get there, and which cogs in the system need to be tweaked, adapted, designed or redesigned in order to achieve that. And here is a handful from many outstanding colleagues that are using safety incident report analyses to design interventions to improve future care. We've got Dr. Joy McFadgen, who's a GP, working on improving physical health in prisons. We've got Mrs. Sam Laws, who's working to understand how paramedics can make safety assessments to appropriately keep patients at home. Dr. Tom Purchase, he's designing an intervention right now with parents to support them to speak up for their children when they're worried about the care that they're receiving. Really important work when you might have heard about Martha's Rule, for example, in the media, and that this work is in response to that important challenge that we know our health systems are facing. We've got Dr. Sarah Yardley really passionately working to improve quality and safety of care for those with severe mental health challenges, and particularly when they're encountering end-of-life care, of course, as well. Dr. Yardley is a palliative care consultant also. And then Dr. Ben Bowers, both Dr. Yardley and Dr. Bowers, they're honorary faculty with us at Cardiff. Dr. Yardley's at the University College London and Dr. Bowers is at the University of Cambridge. But we work so closely together, and Dr. Bowers is really leading the way worldwide on how we improve the safety of syringe driver medicines at the end of life, something that's used day in, day out in our healthcare systems. And we're really starting to make headway around how we can optimize such a sad and challenging time for people. They don't need these safety events on top of what they're already going through. And the commitment that we are making, particularly around the end of life care space here, over those projects is trying to really add value to that space. And then finally, Dr. Imogen John is developing a new way of identifying and measuring harm experienced by people that are dying. And we really think that's important, that we do try and maximize and optimize how we can learn from the experiences of everyone across the care continuum. And probably the PISA research group has had a project from birth right through to death. That's for certain. Also, through the different works that I've shared this evening, we have worked closely with policymakers to take important learning from research and empirically feed this forwards into policy. Remember the study I started off with when we identified 3% of those receiving primary care were at risk of significant harm. This opened up a really important dialogue for action with our policy colleagues in NHS England. And it really is rewarding when you can make a difference like this at the highest levels to think that you can help improve the lives of thousands, maybe more, of people that you're never going to meet, but you know they're no different to your own patients, and not least your own family and loved ones. It's incredibly satisfying. And at an international level, our learning has been shared via important technical guidance produced by the World Health Organization in this space. And it's now one of our key functions as a WHO collaborating centre for patient safety learning and improvement here at Cardiff University. But as I mentioned, there are many other sources of data to help understand and learn about the safety of healthcare delivery. And my research group are using these or developing the science to optimize the learning from each of these in so many different ways. Each have their pros, cons, and caveats, each with overlap with the next. And sometimes that's complementary, sometimes unique. And we're doing our best really to share that learning now with the world. So this is, however, the end of the lecture, but perhaps our work with these important data will be the subject, if you like, of a future public lecture. Safe care is designed, and we've so much data to learn from. We are really honing the craft here at Cardiff University to optimise how we extract that learning and take action with it. Please know there's a team of researchers, clinicians, and importantly, even members of the public working here at Cardiff University with many collaborators across Wales, the UK and worldwide seeking to move from this view of patient safety to this one. Diolch yn fawr. Thank you.